Good afternoon, everyone, and welcome to Grand Rounds. My name is Tom Forden, and I'm the organiser and chair of Grand Rounds, along with Leslie Crichton, who has ably stood in for me in the last few weeks whilst I've been off on sick leave. So thanks very much to her. We have a YouTube channel where we're all, if you've missed any of the recent, or in fact, any of the Grand Rounds in the last 6 years, you can go onto the YouTube channel and catch up. We are a little bit behind because of me being off, but I promise I will get on the case and get those videos edited and uploaded as soon as I possibly can. To not miss any, the thing to do is go onto the YouTube channel, like, subscribe, and press the wee bell so you get notifications of new videos. I'm pleased to be back. I missed a couple of Grand Rounds, like I said, because I was off recuperating from surgery. So it's nice to come back and be here. And we're launching into a surgical themed Grand Round today. We've got a distinguished panel of speakers who are going to talk about robotics assisted surgery in Tayside. We had a Grand Round 3 years ago, almost to the day, 3 years ago, from a urology colleague in Glasgow who came to talk about the West of Scotland experience in robotic assisted surgery. And I was, at the time, I remember being just amazed at the speed and accuracy of the surgery, to the point that I actually had to ask if the video had been sped up, but I was assured it was all real time. And I think the plan from there had been to pursue robotic assisted surgery here in Tayside, and this is the fruits of those labors. So there are a panel, they're going to introduce themselves, but I'll just introduce Professor Ghulam Nabi, one of our urology consultants with a specialist interest in uro cancer, and he's going to start the proceedings. Ghulam, thanks very much.
Thanks, Tom. Thanks for introducing, and I do remember because I had introduced Imran from West of Scotland to come here and speak about robotic surgery, and since then we have made huge progress, slow and steady, and we have reached to the point where we would be offering robotic surgery to our patients in Tayside. And this is just the introduction of our consortium, because we have been working very closely and we wanted this to be a multi-specialty setting robot in Tayside. I'm glad that we all work together with management, and we have reached to a point where this would be offered as a routine care, most commonly for patients with cancers, but also some of the benign conditions which otherwise would not have been treated in Tayside. I think one of the most important aspects of this surgery is that people need to understand that this is not a robotic surgery, that robot is not a machine which would be put inside the tummy and would perform complex procedures. It's a surgeon-driven surgery, so it's a master-slave system. At the end of the day, the machine has to be handled by expert surgeons, so it only improves the dexterity and it improves the manipulation and preciseness, but at the end of the day, it's a machine which is under control of surgeons. So it's a multi-component system. If you look at the picture, surgeon is sitting on a console from where he would direct the robotic arms which are put inside the abdomen, and those arms would perform the procedure. Now that has been done by laparoscopic surgery for many years in Tayside, but it's just the vision, the image processing on the cot, which is on the extreme left, you can see in the picture, that would enhance our perhaps appreciation of anatomy and allows the surgeon to make controlled cuts, which translates into less blood loss, less injury to the tissue, and speed of recovery is enhanced. That's why most patients would be back to work sooner than before. That's the whole advantage of having robotic surgery. So if people are new to this minimally invasive surgery, just to remind them that Tayside has been pioneer in minimally access surgery. We were the first one to do robotic laparoscopic cholecystectomy in Tayside, and certainly because of number of advancements, that was the standard of care in 90s and early 2000. and is gradually getting replaced with robotic surgery. And this is basically a extension of the minimally access surgery, but perhaps with a better access, improved outcomes, and higher precision, and most importantly, that improves the standardization of procedure. So you can have the same procedure which a less experienced surgeon can perform, but with the standardizations and expected to have the same outcomes as more experienced surgeons. So it improves the outcome in terms of many advantages, which I've just listed there. So if you look at how the surgery has expanded, and you can see from the market of robotic surgery, it has increased significantly in the last 1 decade, and it's expected to grow significantly higher in the next 2 years. So it's more than 20% increase in the sale of robotic machines world over. And that just shows that how this technology has penetrated into a routine care, healthcare all over the world. And certainly within the UK, it has significantly replaced the conventional laparoscopic surgery in urology, and it's gaining a significant foothold in other surgical specialties as well. If you look at the robot, initially the urology was the pioneering in early 2000 and 2000 up to 2015, but other specialties are growing, and now you can see gynae, general surgery, ENT, they are introducing, and now the orthopedic has also introduced robotic surgery. So all of the specialties are catching up, and it's likely that this would become a standard and routine machine in the hands, or a sort of tool in the hands of surgeons. In urology, there has been significant growth. It was introduced in late 90s and 2000 for prostate in the United States. Manick pioneered this technique and used to take around 6 to 8 hours. That has been reduced to 2.5 hours. And then it has gone to kidneys, adrenals, bladders. And since this introduction in these conditions, its growth has been phenomenal. And most of surgeries performed in most regions are using robotic machines. I mean, that makes sense because if you look at the renal cancer, here is a kidney with a 4-centimeter tumor sitting in one pole of the kidneys. Now, traditionally, if you look at many years back, the whole kidney used to come out. But we realized that even if we remove the part of kidney, do a partial nephrectomy, we can give the same kind of cancer outcome with the additional advantage that those folks who would get whole kidney out would develop renal failure on long term. So actually, you can benefit patients by taking just a small portion of kidney out, leaving the rest of kidney for his renal function to be maintained on long term. And perhaps that's in the best interest of the patient. As you know, renal failure would increase the chance of cardiovascular events and other things. So having realized that to take 4-centimeter tumor out of tummy using 20-centimeter cut does not make sense. So that's where the minimal access surgery has certainly gained. And the robotic surgery, you can increase the precisionness, and you can also suture the defect within the kidney. As you know, the kidney is a very vascular organ, and your suturing has to be perfect, and that's only possible with robots. So these are some of the impending needs for robotic surgery in renal cancer. Similarly, there's another kind of tumor which happens in the tube which carries urine from kidney into bladder, and there's a filling defect here. Traditionally, this surgery is done by 2 cuts, one in the upper part of tummy and one in the lower part of tummy. But if you have a robot which can be placed inside tummy through different ports, you can actually change the port. You can put the camera from lower port and upper port depending upon which end of the surgical procedure you're performing, and you can perform the surgery without making cuts. So this is again a significant advancement in terms of minimal access surgery, because this is where the laparoscopy had perhaps limitation, and now the robotic surgery would take us closer to actually performing the minimal access surgery. Urinary bladder cancer. So if the whole bladder comes out, there's a bladder here along with the prostate, and then both ureters need to be put into a piece of bowel, and they need to be brought up onto the tummy for the urine to flow, urostomy. And this all can be done by robotic surgery. It involves a complex excision, both of bladder as well as lymph nodes, but it also involves complex reconstruction that's to make a conduit which can be draining all the time on the abdomen. And for that, robotic surgery with its preciseness, suturing, making it extremely easy is a significant advantage, and this would be offered to the patients with bladder cancer in the future. And it's being offered elsewhere, and hopefully we should be offering that in the next couple of years in Tayside. But the most important cancer, which has been the pioneering condition for robotic surgery, is the prostate cancer. The reason for that is that the organ sits deep in the pelvis, and access to that organ used to be difficult, and the dissection used to be in areas where you couldn't see much. With laparoscopic surgery and robotic surgery, certainly that is become now accessible, and you can do the precise movements, because this surgery not only carries the surgery is not only performed for the control of cancer, but also making sure that you preserve the essential organs like neurovascular bundles and sphincter for patients to have functional outcomes. So this is where the surgery has made a huge advancement, because you could see the tissue plane with the preciseness, and you can go into these planes and dissect that precisely. If you look at the evolution of robotic prostatectomy in UK, in 2014, there were only 57% of the patients in UK who were getting robotic prostatectomy. That has increased to 92%. And open surgery is almost less than 3%. And laparoscopic surgery, which didn't pick up much. And because the laparoscopic surgery, both in terms of vision and in terms of ergonomics, was a difficult surgery. So the robotic has picked that up. It's brought the minimal access surgery advantage to the doorsteps of many, and that you can see that has translated that 90 to 95% prostatectomies in this country are done by robotic through robotic access. Scotland, robot has been introduced in Aberdeen in 2015. Shortly after that, robot was introduced in Glasgow and Edinburgh. We had our own struggle to get this introduced in Tayside, and there are other centers which are very keen to get this, and you can see almost all the centers have their names put onto the web or into the internet or somewhere they have been in, starting from Glasgow to Aberdeen to Edinburgh, and you can see that now that has been introduced in Tayside, and on the bottom you can see most of my colleagues and myself standing there with a smile on our face that our efforts have been converted into a real advantage of having this technology in Tayside. But certainly we are still in a process of getting that implemented. But how this would be implemented by a consortium of surgeons, starting with the head and neck surgery, upper GI, colorectal, and gynecology and urology. And that's where the evidence for healthcare system is growing. And that's where perhaps you could utilize the robot in the best way. Now, having said that, I will pass on to my colleague, Jay, who would start with head and neck surgery. He had a fellowship when he joined Tayside, and his hands have been itching for a long time to get them on robotic surgery, and I'm sure he would tell you what the advantage it would bring to his specialty. So over to you, Jay.
Just in case you're speaking, Jay, you're muted. Yeah, sorry, this is a joint presentation between myself and my colleague, Mr. Majumder. The technology has become more realistic. That's the point I want to stress. So this technology could be converted into improve a patient's care. Particularly, it is very relevant for head and neck cancers. This talk mainly just 10 minutes just to focus on ENT perspective. You can see this picture. It is inside the mouth, tonsil. Three instruments are playing very happily in a very expanded field. That itself shows how much use you can get it from the robot. So clearly the benefits are it's quicker and they can go back to mainstream very quickly and could avoid complex operations and technically it's more easier and also reduces hospital stay and last but not least it's minimally invasive. I find this one is very useful because you don't need to work very closely with the anesthetist. The anesthetist can be far away from you or you can be far away from the patient. So you could avoid potential conflicts like punching the anesthetist, which has happened in our country. So this is a simplistic kind of explanation why it is useful in transoral robotic surgery. This is the camera and two instruments goes inside. That creates loads of room, so you don't have to technically split the jaw, mandible, which is being kind of technically abandoned for tonsil and tongue-based cancers because of increased morbidity, and these patients never leave the hospital and doesn't increase the survival. That's how the robot is being introduced for head and neck cancers, particularly in the field of ENT. You can see the rings. You can approach the nasopharynx, pharynx, and also like tongue base and the tonsil region, and to some extent hypopharynx through the mouth comfortably. So commonly used in tonsil cancers and unknown primary cancer is one of the big area in the head and neck. A patient present with the multiple neck lumps, but we will be searching for the primary in the pharynx and larynx. So those cases, a robot makes a huge difference. And also tongue-based pharyngeal cancers. And interestingly, the parapharyngeal tumor area is a very complex area hidden in between the mouth and the external neck that can be approached as well. And there's other benign indications like sleep apnea, which is one of the, even though we consider as a benign, but that reduces the lifespan of the patients. And in Korea, commonly used in thyroidectomies, and in Belgium, they even do it for laryngectomy, which is far advanced. So at the moment, in the head and neck cancers, main modality of treatment is chemoradiotherapy. Because as I said earlier, we don't do any open surgeries and we don't use any laparoscopic kind of things. But the chemoradiotherapy is a long, kind of few weeks treatment and has got the side effects, and you can see the side effects. Those are really life-changing for patients. Increasingly for the head and neck, we come across Hpv Oropharyngeal Cancer, which is a cervical cancer actually extrapolated into the oropharyngeal cancer and affecting the more and more younger populations around age of 50. And chemoradiotherapy is a one-shot treatment. We can't repeat that when they come back with a second cancer in 20 years down the lane. As you know, in Scotland, people live up to the age of 80 or 85, so there is more likely they can get second cancer in those same areas. So if we use a robotic surgery, there's those patients, if they come back with a second cancer, chemoradiotherapy can be kept as a backup. So this is a simple standardization which has been practiced in Philadelphia, which was first originally introduced many years ago, and removing the cancers from the oral cavity, the tonsil cancers. And this is a quick video from my ex-boss from the Newcastle. You can see he's removing the tonsil cancer. You can see the endotracheal tube. Simple, straightforward. To be honest, it's kind of exaggerated tonsillectomy. So how simple, it makes the job much easier, and remove the tumor, or you can even go back and re-remove the tumor as well if necessary. So that's the just transoral tonsil cancer, and they come back a few weeks later. It's similar. They still have the moistness, can eat and drink, sense of smell and taste is absolutely fine, because chemoradiotherapy destroy all these mucus glands and everything there. Similar way, tongue-based tumors can be removed, and this is, you can see how elegantly the tongue base has been resected with the absolute magnification, which is a real boon for head and neck surgeon and patients. More and more patients with unknown primaries are detected in this way. This is the large kind of 9 centimeter tumor looking in the parapharyngeal space. Normally we split the jaw or approach the neck and all these things, but this one was removed with a day case procedure through the mouth. You can see, and the whole lump was removed, and the patient went home next day. So those are so many advantages for benign as well as malignant head and neck tumors. And particularly this PATHOS trial is a UK-based trial. It's putting focus more on the transoral robotic surgery as for HPV cancers. And they stratify after the surgery. If there is a low risk, these patients go home without any further treatment. If there is intermediate risk, the radiotherapy dose can be reduced, chemotherapy can be cut off. So it is going to be a significant advantage, this trial outcome. And actually our Tayside is being approved 3 years ago, but now we can participate in this trial. And also the Orator trial is clearly showed transoral robotic surgery has a merit over conventional chemoradiotherapy. And it's just last month, this is clear systematic review and meta-analysis clearly showed with the 5,000 patients has got a survival advantage, actually 10% higher survival advantage and 10% disease-free area. Survival includes less complications as well. So in summary, it's minimally invasive for transoral surgery, because you don't even make any holes, unlike, I'm just kidding, for other gynae or abdominal surgery, because there is a natural hole, which is bigger hole, and it is very, very surgeon as well as patient friendly, and there is a big role to help the oncology service for head and neck, and it offers choices to the head and neck cancer patients, and it is clearly a multidisciplinary patient-centered approach. Thank you. Sam, do you want to add a few points on anything? I think I'm done.
Thanks for listening to this. It's a huge advantage to us to have technology like this, especially in head and neck where access is very difficult. I just wanted to point out that we feel very lucky that we have been able to establish ourselves as a group of multidisciplinary surgeons. I think the future is very optimistic for us and the patients in Tayside, because we are able to work together, surgeons all together, and a big multidisciplinary team. Thank you.
Brilliant. And now I think Kalpana is going to talk. He's a senior gynae oncologist, the boss. To me, at least.
Okay, thanks, Jay. Let me just move this. I'm hoping that all of you can hear me. Okay. A very good afternoon. And before I forget, thanks to Dr. Wendy McMillan, my partner in crime. Between 2015 and 2020, we rewrote the business plan for gynae robotic surgery multiple times. And then finally, the robot is here. But I think we wrote perhaps lesser than Ken and Ghulam did. So that's okay. So let me start with the teaser question. What is the probable connection between Loki and today's topic of robotic surgery? If you can type the answers for me in the chat function, and at the end of the talk, let us see if anyone gets the association. I might have a prize if you get the right answer. the association of Loki, and the topic of robotic surgery today. A disclaimer, I don't hold any shares either in the Marvel franchise or the Da Vinci Intuitive, but I think Jay does have some shares. So, and if you do invest in shares, robot is the way forward. So the benefits of robotic surgery has been touched upon by Ghulam and very well described by Jay. All these benefits do apply to gynae surgery as well. So I thought for the next 5 to 6 minutes, I will take you through the role of robotic surgery in gynae cancer surgeries, as well as some benign operations where it would be useful and why it would be useful. So the first thing is endometrial cancer. I think we have done grand rounds already where we have said that where we talked a lot about the impact of obesity on endometrial cancer. There is a direct link, and we have seen that endometrial cancers have increased considerably in numbers because of rising rates of obesity. The traditional way of doing a hysterectomy, which was an open total abdominal hysterectomy, is associated with the increased risk of bleeding, infection, wound breakdown, and venous thromboembolism in women with a high body mass index. Conventional laparoscopic surgery has made it much safer. However, with more and more body mass index, there are technical limitations, longer learning curves for gynae surgeons, and really long surgeries. The record for the longest time that we operated on a patient for a hysterectomy at Tayside is actually 9.5 hours. The gynae registrar actually finished his on-call and came back, and we were still in theater doing the surgery for the patient. Because of the abdominal adiposity and the pressure with the Trendelenburg position, there could be suboptimal peritoneal distension and reduced vision and access into the pelvis. So the two main advantages of the robot in this is the 3D vision and better articulation of instruments, along with improved ergonomics for the operating surgeon. These are, I think, the key game changers for women with high body mass index and endometrial cancer. So this is the data from the hospital episode statistics in England, where they compared for 3 modes of surgery for endometrial cancer. The gray column is open surgery, the blue is laparoscopic, and the dark blue is robotic surgery. You can see that the length of stay was much decreased. Overall complications and conversions to an open surgery are lesser in the robotic arm. Now, moving on to the second role of robotic surgery in endometrial cancer, it can help guide adjuvant treatment. So currently for all high-grade uterine cancers, we do a formal lymphadenectomy. So we removed bilateral pelvic lymph nodes along the iliac vessels. But this has got a risk of morbidity such as postoperative lymphedema and occasional obturator nerve damage. We can move over to sentinel node sampling using the robot, because if we inject the ICG dye, this can be picked up by the robotic camera, and the sentinel node, once it is sent to the lab, if that is positive, we have enough information to give radiotherapy to the patient. If that is negative, then we don't need to give adjuvant external beam radiotherapy. So that actually reduces the morbidity for the patient by avoiding lymphedema due to conventional lymphadenectomy. Moving on to cervical cancer, robotic surgery can be offered to perform curative operations up to stage 1A2. Some of you might be aware of the outcome of a LAC trial. Basically, the laparoscopic surgery for cervical cancer was found to have lesser survival outcomes for patients because of inadequate margins compared to a conventional open surgery. In view of that, we have discontinued, it's nationwide throughout UK, and most of the centers in the world has discontinued minimal access surgery for cervical cancer more than stage 1A2. But there is a new trial that's happening, which is the robotic assisted approach to cervical cancer. They've started recruitment, and the end of the trial would be in 2027. So in future, we might be able to resume minimal access surgery via robot for cervical cancers stage 1B. Moving on to ovarian cancer. Currently, we offer laparoscopic surgery for ovarian masses with low risk of malignancy index. And I think this is where a robot will play a role. However, with masses having a high risk of malignancy index, the gold standard approach is still a midline laparotomy and debulking. But reassuringly, there is a new trial opening up called as the Mirrors, done by Simon Butler Manuel from Guildford. This is evaluating the use of robotic surgery for advanced ovarian cancer. I think this will be really useful because it can reduce the perioperative morbidity for these patients and will help them get back to chemotherapy much earlier than when an open surgery is done. But we'll have to await the outcome of this trial before its adoption in clinical practice. Finally, for vulval cancer, there have been case series and video-based series for groin lymphadenectomy, sentinel lymph node biopsies, but it is not part of a national or regional guideline as yet. Summarizing the role of robotic surgery for gynae cancers and what we can offer for Tayside patients: curative surgery and sentinel lymph node sampling for endometrial cancers, curative surgery up to stage 1A2 in cervical cancer, and those with low risk of malignancy index masses, we can offer as soon as we are given the go date for robotic surgery. So just revisiting the main advantages of using a robot, it's a 3D high definition vision, which is far better than the laparoscopic vision we have currently. The endo-wrist instrumentation is almost 360 degrees, so the robot wrist can articulate a complete 360 degree, which is very good when you're trying to reach those narrow spaces in the pelvis and difficult angles. And the last one is its enhanced ergonomics, because the operating surgeon is sitting in a relaxed position with the shoulders not crunched up, not trying to push the surgeon using a laparoscopic arm. But I should say, usually gynecologists don't hurt anesthetists. Anesthetists are very safe in our theaters. I don't know what happens in ENT theaters, but you don't need to be worried about us. So these three things of 3D vision, enhanced ergonomics, as well as a better articulation of instruments will help even in benign gynae operations, mainly severe endometriosis, where all the planes can be quite obliterated. The rectovaginal space can be approached in a better way. The utrovesical fold of peritoneum can be deflected in a much more slicker way using the robot. Where there's a frozen pelvis because the patient has had multiple previous surgeries, but there is, like, say, for example, an ovarian mass that has to be removed, it can still help. And we are seeing that even for benign gynae operations, we are having to operate on women with high body mass index, and robot will play a role in delivering a safe care bundle for these patients. So what do patients think about the robot? I could find only one study pertaining to gynae. This was done from Sheffield Teaching Hospital. The questionnaire was given to the first set of 140 patients who underwent robotic hysterectomy, and overall about 99% were pleased with the care that they received. So what can we expect from patients when we tell about robotic surgery? I've started to mention to few of my women, few of our patients, and the first reaction I've had are, "Oh, I don't trust the robot, Dr. Ragupathy." Then another one was, "Will you still be in the hospital when I have the surgery, or you're going to leave me with the robot?" So I think our information leaflets have got to be quite robust and say that robot is only a tool. It's an extension of the surgeon's arm. And yes, the surgeon will be very much in the same room. So this is what are we doing currently? This is our current practice. I know that the slide is a bit crowded, but this is the quality performance indicator for laparoscopic, for all the parameters about endometrial cancer in North of Cancer Alliance. And Tayside is currently the top of the leaderboard. Our rates are about 98% laparoscopic success rate of endometrial cancers. In fact, we are among the top in the leaderboard across Scotland. Our longitudinal study of 9 years between 2011, when predominantly it was open surgery, down to 2020, when predominantly we have done only laparoscopic surgeries, we have shown that the length of stay has decreased from 5 days to 1.7 days post-operative. Complication rate has come down from 16% to 4%, and the conversion rate is as little as 2%. I wouldn't say it's a conversion rate, it's because we have, at the outset, I think we have decided for a laparotomy because there was perhaps a coincidental large ovarian mass that can't be done laparoscopically. So it's almost 100% we are offering laparoscopic surgery for our patients with endometrial cancer. So it'll be interesting to see what happens with the introduction of robotic assisted surgery, but then that's a topic for grand round next year, perhaps. So I don't have any actual experience as yet, but I think Ghulam mentioned about it. We are supposed to show at least 40 hours of simulator experience before even we do any kind of practical procedures with the robot. And this is my report card from the simulation program. I spent my annual leave doing this, so I thought I should show off to somebody. So there it is. Those are the figures for all the exercises I've done. So that's me. And I'm hoping, I'm not sure if somebody has come up with the Loki link. No. Loki episode is the same length as robotic hysterectomy. No, it is not. Loki is very short and crisp. It's only for 45 minutes. So I'm like a diehard Marvel fan, and I have to see things first day, first show. And episode 2 of Loki was actually released yesterday, and I couldn't see because I was preparing for the grand rounds. And that's the only link. Okay, thank you all very much. I am handing over now to Mr. Ken Campbell, who will talk about the role of robotic surgery for colorectal cancers and benign surgery. Thank you.
Thank you, Kalpana, and thank you to Ghulam and Sam and Jay, and thank you to Tom for the invitation. Let me see if I can share now. Okay. Is that up on screen for everyone? Yeah, okay, good. So I'm a colorectal surgeon in Ninewells, and I've been given a training lead position for robotic surgery as well. I am going to start with this slide, which is one of our colorectal cancer patients. And that probably doesn't fit the profile that you have in your mind of a colorectal cancer patient. But this is actually something we're dealing with much more now than we were previously. And that's actually reflected in data from across the UK and across North America. And this BMJ leader is based on moves in North America to bring the screening age down from 50 to 45 because of this significant, I mean, really quite seriously significant increase in incidence of colorectal cancer affecting young patients. And this picture here and the picture in the previous slide was Olivia, one of our colorectal cancer patients. And it's quite unnerving to have a reverse of the normal situation where the mother is bringing the daughter in as the patient rather than the reverse situation. And it's an entirely different dynamic that comes up in that conversation. And this is a patient group who want to squeeze every single marginal gain out of their treatment, every form of aggressive treatment, whatever's available internationally, worldwide. And they demand and indeed deserve the best equipment and the best treatment that we can provide. And this is going to be an increasing feature, I think, in colorectal cancer. There's no problem sharing these pictures because one of the coping mechanisms that Olivia had with her diagnosis was to go on a very comprehensive social media documentation and campaign of her diagnosis, and it spilled over to conventional media, as you saw from the previous slide. Now, Olivia had a rectal cancer, and I'm not going to talk about rectal cancer because we've already talked about these access to the pelvis from both Kalpana and Ghulam, and it's all exactly the same problems and issues and exactly the same advantages, so I don't want to repeat that. I'm going to change tack a little bit and go on to another significant finding in colorectal cancer, which is this striking difference that's emerged now between right-sided colon cancer and left-sided, including rectum. And this Medscape leader is based on a publication from very good quality, very well-maintained Swiss registry data. And it looks at several thousand patients going back to 1980, the 1980s. And it documents that during that time period of this study, there's been dramatic improvement in left-sided colorectal cancer. So both started off at the same in 1980, but since then, the left side has improved dramatically. And despite all advances and everything else we're doing in medical care, the right side hasn't changed. So there's a real onus on us, particularly with this younger age group of population, to have a change in strategic management on the right-hand side. We need to do something about this problem. Now, despite all the advances in biologic treatment and genetics and everything else, surgery remains your only chance of cure with colon cancer. And so if we're going to do something with this group of patients, it's something to do with the surgery. Now, this technique called complete mesocolic excision with central vascular ligation has emerged and is noted to produce a better specimen, a more complete excision, better lymph node yield. And these things in the left side of the colon translated into a better outcome, and we believe that they'll do so on the right side. Now, the problem is achieving that type of resection, that complete mesocolic excision and that removal of the specimen right up to the origin of these vessels is quite complex. These are major vessels, that's superior mesenteric vein, superior mesenteric artery, and these branches and tributaries, unfortunately, all subject to quite considerable anatomic variation and quite a lot of morbidity to any damage to the vessels around about there. And there are several publications which support the fact that CME, as it's called, is a better strategy and might improve survival, but they document that there's a higher complication rate. Not only that, it's a much more time-consuming operation with a long learning curve, and that's probably based on the fact that it is complex, and we've previously regarded right hemicolectomy as a standard operation, a sort of training operation in many ways. And everything that's been said about the robot before applies to surgery in this complex area. It's the quality of the vision, the steady camera view, the endorus, the manipulation of the instruments, the high quality instrumentation, everything that helps in performing complex surgery applies here. And in my personal opinion, I think this type of surgery, this complete mesocolic excision, will be every bit as important as the pelvic surgery in the rectum in terms of colorectal cancer. So there's a couple, we've covered a lot of things already which are interchangeable between our specialties. I don't want to repeat things, but I just wanted to emphasize, particularly from a training point of view, some of the important implications of the robotic environment. There's a lot of misinformation that starts, as Kalpana has said. There's the feeling that the robot's doing the operation, that it's autonomous, and of course it's not. But there's a profound change in the operating room environment, and we will look at that. The surgeons are now not at the patient bedside. Changing of instruments or conversion, if you need to intervene as an emergency, is much more complex and important. There's some new challenges to the surgeon with a loss of tactile feedback and what you might call a more complex flight deck. And if we've got time, we need to look at the fact that this piece of equipment, although it was donated by the Scottish government and not purchased by NHS Tayside, is worth over £1.5 million. There's around £100,000 per year maintenance cost, and each operation costs several £100s more. So we need to be working very hard as an organisation to justify and cover those costs. So if we've got time, we might cover that. In terms of the operating environment, if we go back to the 1780s, this would be a typical operating theatre scene, and this would be the layout of the operating theatre. And prominent here would be the burly gentleman holding the patient down so he doesn't move. 100 years later, 1880s, ether is the first major change to that operating room environment. So here there's a much calmer environment, and the surgery is able to proceed in a much more effective way. Within 20 to 30 years of that, we've got Lister, and that's the other profound change in the operating room environment. You can see that we've lost our audience now, but everyone is in an aseptic environment. So that picture is taken from the early 20th century. And if you go to the bottom here, although there's been a major change in equipment over that period of time, the basic operating room layout here is very similar. And it takes into the 21st century before that really changes fundamentally. Here's laparoscopic surgery now, keyhole surgery. And the focus of the operating team here is not into the abdomen and into an open wound, but up onto a screen. But however, the relationship between the patient, the surgeons, the operating team has remained the same. And down in the picture here is that huge leap, the huge quantum leap in that layout that comes from robotics. You can now see the robot, the surgeons are remote from the patient. They might even be in a different room. They're not even looking at the operating setup. They're looking in their consoles. And that's been studied, and it's known to create a number of potential barriers in terms of communication. It's been studied, and there are terms that look at this, such as cognitive distance, but you lose all of that sort of, non-verbal interaction with the team. So I think that's pretty important to address. There are communication aids that come with the robots. So the surgeon has a microphone and speakers to hear what's going on around the table, and the operating console has a microphone and speakers also. So there are ways to offset that. But communication and theatre teamwork is very important. I'm just going to show you a video here, which is still, I think, the world record pit stop in Formula One. And you can see it's so quick that you have to break it down into stages to see what's happening. And indeed, you have to even slow it down, because this pit stop's been studied all around the world in terms of best practice. And you can see these team is totally coordinated. They're changing 4 wheels completely over, putting 4 new wheels on, and getting that Formula One car out of the pit lane in under 2 seconds, which is absolutely remarkable. And this is the type of thing that we need to recreate in the operating theatre, particularly for conversion to emergency surgery. You can see that the robot is a big physical presence around the patient. And if you have to get in and operate and do things, this has to be got out of the way, but it's attached to the patient to various bits of equipment. So here we've got the team from Oxford who are demonstrating a means to, by coordinated, very like that pit stop, interact with the equipment. Each of them knows exactly which arm they're approaching, which bits of equipment they're removing. They're moving in a very ordered, very unhurried way to beautifully undock that piece of equipment and allow emergency surgery in. So it's very much like that pit stop, and that's vital. So the whole team needs to be trained here. Let's just turn briefly to the flight deck. So this is a robotic flight deck, or oops, well, that's actually an F-15, and you can tell that by the weapon system, which give it away. But it's not massively dissimilar to the robot. So here's what the robot looks like on the outside to the surgeon. And once their head is in that environment, they've got a fantastic 3-dimensional view, which we can't recreate here in 2D. But you can see it's a much more complex environment for the surgeon. There are 7 potential controls down here. There's an individual clutch on each arm here. And then this wristed motion controls the endowrist, which we've been talking about. Now, but this very much like Formula One, and indeed like fighter pilots, before you get anywhere near patient interaction, as Kalpana and I think Ghulam have said, you've got this simulation mode. So within our robot, we've got this simulation mode, and all these exercises which Kalpana showed you doing, and very high scores which you've achieved among these multiple modules. Here's an energy module, and there's a whole range of these, and I'll skip over these because we've kind of got the principle of that. Here's one which goes through all the potential advantages in terms of stitching, and you can stitch in all kinds of directions, right-handed, swap over, swap direction to right angles. Now, you probably need to be a surgeon who's tried to do all of this with straight instruments, with no wrists, with two-dimensional view to realize how much an advantage this gives you. But skipping back to the exercise itself, this is one of the most dramatic advantages of the robot. This is within the simulation teaching program. You do this exercise within the simulation and you can see you get a feedback. So it's as if you've got a trainer with you who's now sitting down and telling you how you've done and told you what you need to do and told you what your errors were. And this is all automated. And you can see that you've got the efficiency metrics. It's telling you about your economy of motion. It's telling you about your time. It's told you about excessive needle tissue force, unnecessary instrument collisions, unnecessary use of force. A very, very detailed breakdown. And you can go back and look at that, analyze your performance, go back, do the exercise again, keep going in to achieve over 90 and indeed these very high scores that Kalpana showed you. So there's a very robust way to make sure the surgical team is up to speed with this. That is easily controllable and defined. What we do need to do is make sure that all the other members of that group, everyone contributing to that pit stop. So it's no point having a Formula One vehicle and having a highly trained Formula One driver if you pull into a pit stop and then find that the whole thing falls apart. So there is a mechanism without simulation to train all the other members of the team, but it's all very vital. And it's like a jigsaw. All these pieces have to fit together to get this robotic system to work for the benefit of everyone. If there's time, we might just look at costs. And one of the first concepts to grasp in terms of costs, so there are no unique patient benefits. You don't install the robot and start getting the benefits because you're getting something that wasn't happening before. You aren't, because as Kalpana has said, this is just laparoscopic surgery with all the advantages of laparoscopic surgery, but it's more expensive. And you need to squeeze benefits out. The benefits rely on increasing the incidence of laparoscopic surgery. Now, if you're doing laparoscopic surgery as successfully as Kalpana, that's going to be hard. It's the same with Ghulam, who's already performing laparoscopic prostate surgery, and that's very similar to us in colorectal. So our whole organization, our whole healthcare system is going to have to work extremely hard to squeeze out the marginal gains through this to get the advantages. Now, there's increased precision, there's increased capability, there might be some increased or might be some decrease in complication rate. There is the fluorescence imaging, which Kalpana showed us, which can help us look at reducing complications. But the whole organization needs to be very agile, very switched on in terms of being able to define the total cost of healthcare so that you can look at the episode of healthcare, not just the surgery, and see how you save care with it. And it's probably appropriate for this particular grand round that we look at this marginal gains. This will be a familiar figure to those of you with an interest in cycling, but it's about looking at every single detail of the healthcare episode and squeezing 1% here, maybe 2% there, 1% there, small things that don't look immediately like they're going to make a difference and aren't gaining attention, but it all adds up. And one of the things that we need to concentrate on is enhanced recovery after surgery. And that involves prominently our anesthetic colleagues. And it goes through this whole system in huge detail, 1% gain here, 1% gain there, but all of it adds up to getting the patient out of hospital more quickly. And so I think we've looked at all of this. We can prepare by looking at our preoperative imaging. We can prepare by getting our surgical team up to scratch with simulation exercises, but it has to continue after that. It has to continue into recovery room and post-operative management. And this is not the annotations on this slide are not mine. People have applied this model to healthcare and all sorts of other environments, but it's vital, particularly for those of us who already have a high laparoscopic keyhole success, that if we're going to use this robot and gain something out of it financially, we need this whole team to be functioning very well. We can look, we might skip that, it would be better, but just here is probably the world's best Formula One driver. It's Lewis Hamilton coming in with probably the best car and pit stopping here. And you can see that despite everything he's done in the race up to now, he's gained seconds by little marginal gains here, there, done everything he can. He's put himself 5 seconds ahead, but he comes in for this pretty disastrous pit stop. And you can see he's up to 25 seconds. You saw Red Bull doing that in 2 seconds. So you can see that everything you've done, you can have £1 million worth of Formula One car. You can have a driver that's done simulation exercises up to 99%, but the whole exercise will fail to gain what it needs to gain if all the organization, the teamwork round about it fails. And that was the point I wanted to make about that. So I think it's probably time to stop and hand over to my colleague Pradeep Patil, who's going to tell us how robotics impacts in upper GI surgery. Thanks, Pradeep.
Thanks, Ken. And thanks to Tom for giving the team the opportunity to showcase the introduction of robotic surgery in Tayside to the entire trust. So I'm an upper GI surgeon, mainly interested in esophageal and gastric cancer, and of course, metabolic surgery. I've got a couple of slides on metabolic surgery, but I might skip that and keep this focused to cancer because Kalpana has touched on the high BMI patients needing expertise from laparoscopic and robotic surgery. Now, the team have spoken about the robot, so I will not try and go into that in any more detail. They have mentioned the team in the theater, including the anesthetists and the nurses, which is great. But we also have a wider team in the hospital, and I probably will bring my last slide to show you a story of a patient, how well the whole team in the hospital, including oncologists, radiologists, nurses, etc., have managed to get the best possible outcome, even during the dark year that was last year, COVID. So, but I'll leave that to the last slide. So. So anyway, we can share parts of the operation that we're all good at, as you're sitting at a console away from the patient. So it gives us great mobility and movement in a lot of ways that laparoscopic instruments don't do in very closed spaces inside the human body.
Experts predict robotics will transform surgery in a similar way to keyhole surgery, a technique also pioneered in Dundee.
Coming to the technique of laparoscopic surgery being pioneered in Dundee, Ghulam mentioned it at the beginning, but it's not just the cholecystectomy in Tayside in the UK, but we've been the first in a lot of laparoscopic surgeries in the world, and specifically to me, we're the first center in the world to do laparoscopic esophagectomies, going back 20 or plus, nearly 30 years ago. So we are a hugely talented center in Dundee, and we've carried this through, and I will show you how we've come through the laparoscopic advancements in the last 10 years or so. And we've been waiting for this robot for quite some time. And it's finally here, and we need to make the best use of this possible. So
that can be done.
Gee, this is my fellowship. And I'm going to skip this because that was a hands-on fellowship that I did.
That can be done.
That I did more than 10 years ago. Been waiting for this robot for 10 years. And interestingly, I did that fellowship with an Indian surgeon who was amazing. In fact, the new robot is being trialed there at the moment. He's called Shailesh Pantambekar. And at that time, I met a surgeon from the Netherlands there, Professor Miguel Cuesta. And now Netherlands is one of the biggest centers for laparoscopic or advanced esophageal cancer in the world. In fact, the highest incidence of adenocarcinomas of the esophagus in the world is in the Netherlands and in the UK. And in the UK, it's in Scotland. So this is something which hit off very well with Prof. Cuesta, and I've kept the links with him. And even earlier this year, in fact, we had a live link with the team. He's retired now, and I know the next in charge prof. So this is our laparoscopic demonstration of a meso-esophageal resection like Ken was mentioning. You can again see it was pioneered by Miguel Cuesta. As we're talking through this, I will let you watch the video, but that's the esophageal tumor being resected, staying away from the esophagus. That's the pericardium being exposed, etc., etc. But what's happening here is this is the first stage of the operation. It's like the first half of the Euro Cups, now is the football. So you do the first stage, that's the thoracic aorta being completely delineated. And once you finish the first half, you get a little bit of a break, but the surgeon is in the ring. He has to fight. He is constantly exposed to all the stresses of being there. This is where the robotic fighting comes into place. And by the time you finish stage 1 of the operation, you clear everything and you think, oh my gosh, there's one stage done. Then you need to go to the second half of the operation. So that's the thoracic aorta isolated, clips on this, and then you move into the chest. Now, this is where I think you can see here. Anyway, I'll let you watch the video. This is where I think robotic surgery is a huge benefit to a surgeon, because the instruments, the straight instruments, are going through the ribs. There is very little leeway to move. With the beautiful movements that you get with the robot, you will see it will make such a big difference to us. So not only will it improve the ability of the surgeon to do the operation, that's the right inferior pulmonary vein, by the way. Patient is lying supine after the first stage of the operation. That's the heart in the front, that's the back at the top. So I'm working upside down here. That's the right inferior pulmonary vein, right lung here. Okay. And as we move up, you see the esophagus be protected. Here you can see I'm using a straight instrument. I want to go around and isolate this tumor, but I cannot. And the robot will be a great help for that. That's NHS Tayside locked me out. Okay, that's the aorta being exposed. So that's the back of the heart completely exposed, right inferior pulmonary vein, left inferior pulmonary veins, the aorta being completely skeletonized all the way into the arch. This is where working in a tight space through the ribs with straight instruments is a huge, 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 huge ergonomic problem, which the robot addresses. We've been waiting for this for 10 years. I'm just so glad it's here now. And even as the stapler goes in, you will realize, or you might not, how difficult it is to get in. And that's the right back of the trachea, right bronchus, left bronchus, arch of the aorta. You can see there, it's all finished. Now, this is only 90 minutes of the football game, and you think that's done. The most difficult part comes in now. You actually have to do the anastomosis, which is even more difficult. So I think for upper GI or esophageal surgery, this is going to be amazing. If I can only move to the next slide. That's right. Okay. So we think upper GI is going to be a huge benefit. We know that laparoscopic surgery is equal to open surgery, but that is proof from elsewhere. I can show you our own proof. These are two of our patients. One is a young fireman. You can see there, his fireman's bleep is still there. The other is an 80-year-old ex-Marine. Now, both of these had laparoscopic 2-stage, no big cuts in the abdomen, no big cuts in the chest. You can't even tell they've had esophagectomies. The fireman went back to full-time work as a fireman 6 months after surgery, which is unheard of in open surgery. We can make this better with robotic surgery. Now, the Marine, 80-year-old, he wanted to attend his 80th Marine. Apparently, all the Marines get a big a party or at 80, and he attended that. That's all he wanted to do. He's still doing fine. But this is what laparoscopic surgery can achieve with a lot of difficulty for the surgeon. Robotic surgery will make it easier for us. I don't need to be in the ring fighting. I can be sitting out and I can work with so much freedom and have the best efficiency till the end of the operation. So this is again a very recent study showing that outcomes in robotic surgery are actually excellent, and we should be giving this to our patients in Tayside, and we should be doing it early. Now, this is esophageal cancer. I was going to talk about some of our amazing results to do with metabolic surgery, but I'm going to keep this to cancer as such. So I'm going to skip past these. Maybe it's time to come back to these slides in a different grand round. I'll approach Tom for that, but I'm going to leave you with a nice story about how the whole hospital is working for the benefit of our patients in Tayside. This is the story of a man who had a nasty cancer, and he had his neoadjuvant, he had his So you can see the PET scan here, big cancer in the stomach. You can see lymph nodes. So the plan was multimodal treatment. Professor Petty gave him 4 cycles of chemotherapy and had a check PET scan afterwards. And you can see it's getting better. It's lesser. However, this was in the middle of the pandemic. And in March of last year, we couldn't bring him in to do an operation. And so we decided we'll wait and see how things go. So we gave him another 4 cycles of FLOT, which is new though. This is called, that's why we're calling it total neoadjuvant chemotherapy. We've got the expertise in oncologists. Now come to other places. Sean from pathology, of course, I've got Prasad here from radiology. The intervention radiologists here are amazing, fantastic hospital who can do all this for our patients. So we give them another 4 cycles of chemotherapy, and luckily we fell into a window, you know, where he had this eat out to stuff in August. So he came in, again, a fantastic green, clean pathway. I think Tayside was a leader in that. Patient came in, had a laparoscopic subtotal D2 gastrectomy. We used half of his gastrectomy scar to take out his gastrectomy specimen of his appendicectomy scar, sorry. And can you imagine, probably the first report, we're publishing this, of complete response. This is how well the hospital or the trust can work despite the dark COVID pandemic. Everybody, oncologists, radiologists, surgeons, anesthetists, et cetera, we have a good team, and we can definitely use the robot for the best outcome for us and for our patients. I think this was long-term due for us, and I think we will move forward. And it's great to work with the rest of the team here, because this is only one of the few multidisciplinary centers set up for the introduction of robotic surgery that I know of. In fact, I don't know of any. Maybe my other colleagues will correct me. So with this sort of good news, I'm going to stop and hand back to either Ghulam or to Tom. Thank you, everybody.
Thanks very much to the team there. Ghulam, have you got any other closing comments? I appreciate we've overrun slightly.
Tom, Ghulam asked me to summarize it because he had to go to theatre.
Okay.
So just, you know, thank you all so much, and thanks to Tom for giving us this opportunity. Just wanted to summarize to say 2 things, that the clinical governance is extremely tight around robotic surgery. There has been a huge investment in the simulation-based exercises, and I think this is going to be the first surgical platform where there will be ongoing collection of data and looking at adverse events on a prospective basis. And the patients need to be aware that this is only a tool or an extension of the surgeon's arm. The second thing is the group of surgeons are extremely committed and enthusiastic. I think for the first time, you know, we came together for a common cause. It's almost as though we are friends, which I didn't think was possible previously. So all we need is the go date for robotic surgery, and we are ready to go. We just need the go date from the management team at Tayside. Thank you all very much.
Thanks very much to the team for a really fascinating talk. I think, you know, way with the future. If you'd said to me when I was at medical school that we'd be operating the robots within my career, I think I'd have thought you were talking about the latest Terminator movie. But this is amazing stuff. And I can only presume it'll be the first purchase of many robots, and we'll be at the point soon enough where we'll be operating with the operator maybe in one city and the patient in another one. So maybe that's something to talk about next time. Okay, I will welcome you back to Grand Round. If you've got with some of your increasing experience with these findings, and Pradeep, some of your metabolic stuff, that'd be very interesting. Next week, there's no Grand Round. I don't have a speaker, but we've run out of people to speak for a little while. So you get a week off. But I'm looking for more people to speak. So if you're sat in the audience or you're watching this on YouTube and you have a burning topic you'd like to talk about, please get in touch, as we've got slots all the way through from in July, August, September, and on to Christmas. So please do get in touch. Thanks once again. I will beaver away and upload this to YouTube. Thanks again.
Thanks, Tom.
Thank you.
Thank you. Bye.